Well, thank you, everyone. It's really great to be with you all today, and I want to thank the planning committee for inviting me today. I am really excited to speak with you about work I've been doing for the greater part of the last decade, which is really work on how to value what physicians do monetarily, and also how to specifically recognize the value of cognitive services, say, as opposed to procedures. And I do that through several committees at ACP and also through the American Medical Association Relative Value Update Committee, also known as the RUC, which you will learn plays a pretty significant role in determining what physicians get paid. So today is basically somewhat of a policy discussion. I don't have any relevant financial disclosures. I have served on the RUC in various capacities from 2012 to 2019, and I'm still somewhat peripherally involved even today. I am on the board of regents, essentially the board of directors of ACP, and I will be referring to some ACP policy. And let me just close my camera for a second. I think the most important disclosure I have is that I am an internist. I'm a primary care physician. I do mostly cognitive work. I do very few procedures. And that has instilled in me a certain viewpoint about how physicians get paid. And that bias is likely to come through during the course of the discussion today. I wanted to start with a little bit of a kind of thought exercise. We are all familiar with an EKG. An EKG is assigned a CPT or Common Procedural Terminology Code 93000. It is valued at 0.17 RVUs or relative value units. And for reading an EKG, Medicare will pay you about $17.30. Cryotherapy valued at 0.61 RVUs. You get paid from Medicare $66 and change for freezing off an actinic keratosis. We are all familiar with a moderately complex E&M code 99214. It is valued, at least it was valued in 2020 at 1.5 RVUs, and I'll get to 2021 and 2022 later in the talk. But payment for a 99214 in 2020, $110. And you can see cataract 8.52 RVUs, $654, knee replacement 20.72, $1,408. So my question is why? Why are these the way they are? Who gets to decide that anyway? And does it make sense? So my learning objectives today, I want to review the historical context of physician payment, discuss the process by which codes are valued by the Relative Value Update Committee. Then I want to speak briefly about the new E&M documentation and coding requirements and the valuation changes that went into effect January 1, 2021. And then finally, consider the potential benefits of payment models other than fee for service. But first, I want to talk a little bit about the history of physician fees. How did we end up with the system that we have today? And you can decide, is this a history? Is it a comedy? Is it a tragedy? So in the beginning, we had this concept of usual and customary charges. There was a limited regulatory framework in this country, and that allowed fee for service to thrive. Now, common minimum fee schedules did exist, but they were mostly there as a bulwark against price deflation. They were mostly meant to protect physicians. Physicians were considered one of the learned professions, and so they could be trusted to set reasonable fees, and they were exempt from antitrust laws. So as long as the fee increases were not unreasonable or dramatic, there was limited pushback, and insurance companies would simply pass along the fee increases in the form of higher premiums. Now, after the war, we begin to have the origin of a standardized nomenclature. Third party payers began playing an ever expanding role after 1945. And the House of Medicine recognized the need to define and standardize descriptions of physician services and formalize reimbursement in order to more easily interact with these insurance companies. By taking a proactive role, physicians could maintain control over what exactly was a medical service and preempt other actors from defining it instead. And to that end, the American Medical Association published its first nomenclature called Common Procedural Terminology in the year I was born, 1966. It contained 2,084 distinct services. Now, in California, the California Medical Society took the first major step in developing a uniform fee schedule for its members as a service so its members might be able to figure out what they should charge for various services, and they based it on a relative value system. So all innovation comes out of California. Now, here is the CPT book in 2021. Some of you may be familiar with this book. Others of you may never have seen it. It is certainly sitting in the on the desk of your office administrator or your front desk staff. It is now about 2 inches thick, and it contains over 8,000 distinct physician codes. Now, moving ahead to modern times, we begin to have a formal development of something called the resource-based relative value scale. So in the 1970s, Medicare expenditures began to grow, and this raised alarm in Congress. Around the same time, the Supreme Court found that, guess what? Physicians were no longer exempt from antitrust laws. So this was the beginning of the end of that California Medical Society relative value scale system, and the beginning of Medicare developing its own relative value scale to determine how it would pay physicians. In the 1980s, Medicare relied on the work by William Shao at the Harvard School of Public Health to form the blueprint of this new system. And finally, in 1989, with the passage of the Omnibus Reconciliation Act, that permanently switches Medicare over to this resource-based relative value scale payment schedule. Now, I started medical school in 1990, so I have never known a system without the RBRVS, but there may be several people in the audience today who have practiced before that time, and that commentary might be very interesting during the question and answer session. I do think that we are now in an Act 4, a postmodern era with payment tied to quality, value-based contracting, partial or full capitation, and shared savings. However, at the individual physician level, even these newer payment models are built on an RVU chassis. A recent study demonstrated that 73% of physicians surveyed reported payment and bonuses still tied in whole or in part to the RVU system. Now, here we are with William Shao. Remember, he is the architect of this RBRVS system from the Harvard School of Public Health, and he published a series of articles in the late 1980s in JAMA in the New England Journal of Medicine, outlining his methodology and the implications for switching over to an RBRVS system. And I'll just read you a little bit from his abstract here. We surveyed approximately 850 physicians in 8 surgical specialties to investigate physicians' work in performing invasive services. Building on our analysis of physician work, we developed a relative value scale of physician services based on resource costs. So what he's trying to do is he's trying to figure out what are the specific actual resources going into every procedure, and that's how we should pay for each procedure. Now, this last line should probably come as no surprise to any of you in the audience, but we found that physician charges are not set in proportion to the resources required to perform a given procedure. So I do want to take a step back and talk a little bit about definitions I've been throwing around. First of all, what is a relative value scale? Well, that's simply a system of assigning value to something in comparison to other similar items. So a very simple example of a relative value scale on the right of the screen, shades of lightness or shades of darkness depending on the perspective. So what is a resource-based relative value scale? That's a system of assigning unit values to medical services in relation to one another based on the skill, the time, and the equipment required by clinicians to complete any given service. So the resource-based relative value scale tries to get at what are the resources that go into a particular procedure. And when Shao studied the resources, he included the physician time spent on the service or the visit, the intensity or what we call the mental effort, the practice costs, which include supplies, equipment, and non-physician manpower, supplies being things like latex exam gloves and table paper, equipment, things like the exam table itself or the otoscope, ophthalmoscope, or colonoscopy equipment, and non-physician manpower, the medical assistants, the RNs, the LPNs who make up part of our team. He also included something called the opportunity cost, the income foregone when additional years of training are pursued, but this has now been replaced by malpractice costs. So again, for a resource-based relative value scale, each of these components in red is assigned its own relative value unit. Time and intensity is known as work. That's given a W or work RVU. Practice expense, a PE RVU. And malpractice expense, a liability RVU. You simply add all these RVUs together. That gives you the total RVU of your service. And then you multiply that by the Medicare conversion factor, which is the amount Medicare will pay per RVU, and that will give you the reimbursement of your procedure. So taking a deep dive into the anatomy of a 99214, in 2020, 1.5 work RVUs, it had 1.46 practice expense RVUs, malpractice 0.1, total RVU of a 99214 in 2020, 3.06. You multiply that by the conversion factor in 2020, $36.09, and that's how you come up with $110 to be reimbursed for a 99214. Now, a little bit of good news that I'll get to later in the talk, but in 2022 and beginning January 1, 2021 actually, the work RVU of a 99214 is now 1.92. The total RVU has gone up to 3.81. The conversion factor has come down a little bit, but the total remuneration has actually gone up substantially. We'll get to that in a little bit. I spent some time talking about what the RBRVS is. I do want to spend a moment talking about what it is not. It is not a way to incentivize value in our healthcare system. If you take a look at this cartoon, don't rush me, right? I get paid by the hour. But in our RBRVS fee-for-service system, you could easily change the caption to I do more possibly unnecessary work because I get paid more for it. This slide is really just meant to be a reminder that as we transition to new payment models, we need to keep the patient at the center of the equation and align our incentives appropriately toward quality and not necessarily volume. So I hope I haven't confused you too much about the RBRVS system, but I do want to turn my attention now to what is the RUC and what is the role of the RUC in determining these values. So again, the RUC stands for the Relative Value Scale Update Committee. It is a multi-specialty committee of the American Medical Association. It is charged with using Shao methodology, meaning surveys, to physicians to study the resource costs of CPT codes and make recommendations to Medicare as to their value. Now, it was formed in 1992, obviously in response to the methodology change in how Medicare pays physicians. But I think the most important thing you can understand about the RUC is that it is a zero-sum game. This is the physician fee schedule pie, and there is a limited amount of money in that pie. It's about 80 to 85 billion dollars, and it really doesn't change much from year to year unless Congress infuses it with more money. So, if a new code is introduced into the fee schedule, or if the value of an existing code goes up, then there has to be a way to pay for it. And the way to do that is the value of every other code must be taken down a notch to pay for that code that has increased in value, or to pay for that new code. And the way that's done in actuality is the conversion factor will go down just a little bit to provide that extra money. So you can imagine it's a little bit intimidating, I think, to serve on a committee like this because you're dealing with some of the smartest people across all of the medical specialties. And it's kind of like a game of high stakes poker because I think everyone understands the stakes. And if you make changes in the value of any procedure, you could be transferring tens of millions of dollars, hundreds of millions of dollars, or even as we saw in 2021, billions of dollars from one group of physicians to another group of physicians. Now, this picture, by the way, is not a picture of the actual RUC. It's a picture from one of my favorite TV shows from the 1990s, The X-Files. But this is a picture of the actual RUC, and I did want to spend a few minutes and just kind of give you the lay of the land here as to what's going on. The RUC meets 3 times a year. It meets twice a year in Chicago, and when it does, it takes over an entire ballroom in a hotel in downtown Chicago. They also meet in the wintertime, and they pick a warmer climate compared to Chicago, of course. The RUC meets for 3 to 4 days at a time. These are lengthy and involved and very intense meetings that last anywhere from 10 to 12 hours a day. At the head of the table is the RUC leadership, including the chair of the RUC right here. At this corner are members of Medicare, because Medicare is going to be the ultimate decider in terms of what the value of any given procedure is, but they are intensely involved in the conversation and paying close attention to the events that are going on. These folks lining the sides of the table, these are the actual voting members and alternates of the RUC. They are going to vote up or down on the value of any given procedure. And then these folks sitting at the end of the table, these are what we call the RUC presenters or the RUC advisors. Now they are sitting before the RUC and they are advocating as to the value of a particular procedure. When I took this picture, they were actually debating the Advanced Care Planning Code for them, some of you who use that code. Now, these folks are not a disinterested party. They are very invested in the code, and they are going to try to get from the RUC the highest value they possibly can. But these folks lining the sides of the table, they're very discriminating sorts. They do not want to overvalue this code. They understand the stakes involved. Now, they don't want to undervalue it either. They're really trying to get at what is the right value of this code, but they are going to find flaws in the presenter's data, holes in their argument. In general, it's very tough to be at this part of the table, a lot of tough incoming questions, and usually you walk away from the table not really getting everything that you had hoped for. Now, I panned out a bit to take a larger picture of the room just to let you know there are hundreds of people watching these proceedings. It's somewhat of a closed door meeting in that you have to sign a non-disclosure agreement, but hundreds of representatives from all the specialty societies are paying very close attention to what's happening. They know that the change in the value of any specific code can have significant economic implications for their membership. So just to review, the RUC has 31 voting physician members, hundreds of medical advisors. There's a chairperson. There is an entire committee devoted to practice expense, and the chair of that is a voting member of the RUC. There are 21 physicians from these major medical societies that you see here. There are 4 rotating members for those societies that don't have a permanent seat, and there's also a variety of additional slots. Now, they use this shall methodology, which again means that they are sending out surveys to physicians to determine what is the time and intensity and equipment involved in conducting any particular procedure. Now, some of you in the audience may have from time to time gotten an email from AMA asking you to fill out one of these surveys. If you have, you may recall that these are kind of lengthy and even somewhat complicated surveys, but I would say this: if you ever get one of these emails, it can be very helpful to the process to fill out these surveys. And all we ask is that you be as honest and accurate as you can in your assessment. Now, it does take a 2/3 supermajority to approve the value of any given code. And a lot of people point to that as a legitimate criticism of the RUC process, because as you can see, most of the members who form the voting membership of the RUC come from societies that are procedurally based societies. And a lot of people point to that as a reason why it's been historically so difficult to increase the value of what we see as the undervalued E&M code set. So I do want to talk a little bit about changes that began in 2021. In 2019, I had the honor, along with a couple of my colleagues, and there's me sitting before the RUC there, to go before the RUC and make an argument that E&M services were undervalued and that the values needed to go up. And amazingly, I was able to convince 2/3 of the RUC to go along with that proposal. And what we got is a significant simplification of our E&M documentation guidelines and significant increases in the values for our E&M codes. And I'll go into a little bit of that in a moment. Now, this slide is meant to be purposefully confusing and impossible to decipher because it represents the way we had to code prior to January 1, 2021. And if you recall, at that time, the coding scheme was comprised of history, which itself had a lot of different parts, including chief complaint, history of present illness, review of systems, past family medical, and social history. And you had to achieve a certain level in order to get credit for the history. On exam, you had to achieve a certain number of bullet points of exam in order to get credit for the exam. And this part here represents medical decision making, and you had to achieve a certain level in order to get credit for medical decision making. So what did the CPT RUC process do that simplified things? Well, first, we eliminated history as a required element of documentation and coding. And we eliminated examination as a required element of documentation and coding. We kept medical decision making, but I feel we clarified it and simplified it to make it a lot easier to understand. So basically now there are two options for you to choose a level of service, and pay attention to this slide because it's your maintenance of certification question slide. You can select the appropriate level of E&M services based on either one, the level of medical decision making as defined for each level of service, or two, the total time that you spend on the date of the encounter. So let me just back up and say a word about history and physical examination. This is what Medicare said in their rule regarding history and physical. Office or other outpatient services include a medically appropriate history and/or physical examination when performed. But the nature and extent of the history and physical exam, you get to decide that. It is determined by the treating physician. If you don't think there needs to be a history or physical, you don't have to include it. Now, there are a lot of important reasons why you might want to write a good history. This is the logic that you are laying down. This is the way you communicate to the rest of the healthcare team what you think is going on. And of course, there are important medical legal reasons why you would want to write a good history and physical. But the important thing is that history and physical are not required elements in determining the level of the visit. So I do want to come back to this slide to say that we were able, after our presentation, to get very significant increases in the RVU values. And I want to talk about that a little bit because I think it's important. And this table is for facility charges. There's an analogous table for non-facility charges. This is the CPT code set for E&M codes. And in 2020, this was the total RVU that we were able to get for each of these visit levels. Now, after our presentation to the RUC, we were able to get these RVU levels for each level of service, and that represented anywhere from a 4 to 47% increase in RVUs. And for the codes I think we use the most, anywhere from a 30 to 36% increase in RVUs. And the actual remuneration went up by 25 to 31% for the codes that we use the most. And here's the analogous table, which is very similar but not identical for non-facility charges. Now, why is this important? Well, I think it's self-evident for all cognitive specialties, of course, but I do want to specifically call out primary care. Only between 5 and 7% of healthcare dollars are spent on primary care. But primary care is like the only specialty that is associated with decreased health expenditures, higher patient satisfaction, fewer hospitalizations and ER visits, and lower mortality. So it's really important that we increase funding for primary care. And there are a lot of ways to do that, but one way is to increase the value of the E&M codes. So I do feel that we have made some progress. Now, normally at this point, I would go through a whole series of slides that goes over how do you bill a level 2, a level 3, a level 4, a level 5. But we are now over an entire year into this new coding and documentation scheme. So I am hopeful that most of you already understand all of that. If you do want some extra tips and tricks, I'd be happy to send you an extra slide set on just how to document and code each level. But I thought instead that I would kind of pursue in the last part of this discussion just a few slides about, is fee-for-service really the best way to pay physicians, or should we consider moving on to a better way? And I want you to consider the following. First of all, internal medicine and other cognitive physicians have not really fared well under fee-for-service. Number two, fee-for-service misaligns our incentives, as I alluded to earlier. Number three, fee-for-service doesn't really fit with how physicians work in the modern era. We've learned that fee-for-service is not pandemic-proof. And finally, fee-for-service doesn't really improve health equity. And I want to go through each of these points in turn. First of all, internal medicine doctors have not fared well under fee-for-service. We still remain kind of at the bottom. And this survey comes from Medscape, and it was done in April 2021. And it says that on average, internal medicine physicians make about $248,000. Well, I've been practicing for a bunch of years now, and I've never made anywhere near that salary, I'm sorry to say. But in any event, there does remain large differentials in salaries across medical specialties that are probably inappropriate. And I do feel that future prospects under our current system remain a challenge. So we talked a little bit about the conversion factor, the amount Medicare pays per RVU, after jumping up from 1992 to 96 all the way up to about $38. You can see it's been a very rocky road for the Medicare conversion factor, and actually there's a downward trend here. And I do think that there is going to be continue to be downward pressure on the conversion factor over time, which is going to make it harder and harder for physician payments for cognitive services to remain stable in the near and medium terms. Number two, fee-for-service really misaligns incentives. And in May of 2021, the National Academy of Science, Engineering, and Medicine released this report called Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. And in this report, which was sponsored in part by ACP, the National Academy said that primary care is vital. Primary care is a public good, but it is slowly dying. And here is what they found. They said fee-for-service focuses on delivering specific reimbursable services centered around a disease process, and the result is increased healthcare spending, widening disparities, and inequitable health outcomes. It does not foster team-based care or the integrated whole person approach. And according to the National Academies, they said we should be paying for primary care teams to care for people, not for doctors to deliver discrete services. Number three, fee-for-service doesn't really fit with how we care for patients in the modern era. So in the 1920s, here we have the classic physician making a house call. Fast forward to the 1970s, I think office medicine reigned supreme. Now we're up to 2022. Of course, office medicine is still a large part of what we do, but we're also delivering care via telemedicine. We're delivering care via multiple phone calls. We have the patient portal, which connects the patients to us 24 hours a day, 7 days a week, 365 days a year. There is remote patient monitoring that we are doing. Patients are texting us. They are direct messaging us on Twitter. They are Facebook messengering us. So think about all the different ways that patients and physicians are interacting. Over the past decade, the CPT RUC process has developed all of these new codes to try to keep up with how we are taking care of patients in the modern era. And I was part of developing some of these codes. But it is all very confusing as to when we use these codes, and there are very high opportunity costs to bill for all of these discrete parcels of time. And it almost seems like when we use these, we're nickel and diming our patients. Physicians, as we know, have to do a lot more care coordination, and fee-for-service doesn't necessarily reflect that. The proportion of beneficiaries who are seeing 5 or more physicians annually, which is this line here, has increased from 17.5% in 2000 to 30.1% in 2019. And these researchers said the following. They said the work necessary to follow, understand, and coordinate healthcare of a patient panel was more complex and time-consuming in 2019 than it was in 2000. The average PCP in 2019 must hypothetically interact with close to double the number of specialists compared to 2 decades ago to understand the care received by their patients. And this is not the most optimistic headline, but this really speaks to the challenges of care coordination. And this research put together by folks at University of Michigan is basically the work of our inbox. So here are all the inbox tasks: 17,500 per year, 390 per week. It takes 1,199 minutes per week to do this, essentially 20 hours. And here's what the researcher said. So-called face-to-face clinical time must be redefined to reflect the reality of practice in today's environment. Our data suggests that a full-time primary care clinician should have 24 rather than 32 hours of face-to-face clinical time, with an associated 20 hours of virtual visit and administrative activity weekly. And we're not going to get there, or we're not going to be able to pay for physicians to do that under our current fee-for-system model. Fee-for-service is not pandemic proof. Look at the decline in visits at the beginning of the pandemic. This reflects my own personal experience. Fee-for-service basically means you have to see the patient in the office in front of you, in order to be reimbursed. Of course, that depends on the future of any telehealth legislation. But according to an article in Health Affairs from 2020, the average full-time equivalent primary care physician lost $67,000. The total loss to primary care was estimated to be over $15 billion. And most of our practices and most of medicine was really propped up by the Paycheck Protection Program and the CARES Act. Finally, fee-for-service doesn't really improve health equity. I want you to consider these two patients. These are based on patients in my own practice. We have first a 68-year-old college professor with hypertension and hyperlipidemia. She does cardiovascular activity 4 days a week, eats lots of fresh fruits and vegetables, no difficulty affording her medications. She reliably comes to the office for 2 visits each year. I think that's a situation where, yeah, fee-for-service seems to work well there. But let's look at the next patient. 84-year-old retired church administrative assistant, hypertension, hyperlipidemia, diabetes, obesity, CVA with ongoing deficits, dementia, opioid requiring end-stage osteoarthritis, frailty. Very hard for her to afford her multiple medications, needs a lot of social support and services in order to stay independent. She has only one daughter in the area. That daughter works 2 jobs, has trouble taking the time off to bring her mom to visits. She's scheduled for 4 visits per year, but most of these visits are missed. So that leads to numerous care by phone call with the daughter, numerous house calls, etc. That one, I think I could submit to you, that doesn't really work well in a fee-for-service payment system. So I'm not saying that I have all the answers here, but I do want you to consider the following as a potential approach to how we could consider new payment options. First, value must always be defined with patients and families at the center. We must begin to adopt population-based prospective payment models for primary and comprehensive care that are structured and sufficient to ensure access to the needed care and address the needs of individuals experiencing healthcare disparities. Healthcare delivery and payment should be redesigned to support physician-led, team-based care delivery models. There is not a one-size-fits-all approach to reforming delivery and payment systems, and a variety of approaches should be considered, evaluated, and expanded. And finally, we should prioritize inclusion of underserved patient populations in all value-based payment models. So I think that's the balance of my time, and I want to thank you so much for considering my discussion, and I think we'll end it here, and I look forward to any comments or questions during the Q&A session. Thank you.